Hello, everyone. Good evening, and thank you for coming to my not live presentation of supporting lactation challenges and best practices. I am coming to you from earlier in the day because I have 4 children who will be running around the house at 6 p.m. I will join on, but I just thought this might be quieter. So without any further ado, let's get started. So just financial disclosures. I am the CEO and co-founder of a breast pump lactation innovation company called Libby. We will not be talking about it today. I'm also on the advisory board of another biomedical company called Avita Life. And a lot of my research has been funded by the Georgia Research Alliance, as well as currently funded by the NIH for research, again, that is unrelated to this presentation. So I usually like to start my breastfeeding talks by telling you why I give breastfeeding talks. And it's really important for me to let you know that this is a passion of mine to educate providers and patients in a more adequate way than I was educated myself. This is an important picture to me because this is during my 4th year of residency after I had my first baby as a 3rd-year resident at UConn OBGYN. And you know, what I know now looking back is that I suffered with postpartum depression for my last year of residency. And most of it had to do with my perceived failure of being able to breastfeed my child. That's a whole different lecture altogether, but the important thing for you to know is that organic and that native need to take care of my child and feeling like I had to struggle between choosing to feed my child the way I wanted to and be a good doctor really pushed me in a direction that, was a pretty dark place in my life. I actually almost quit my job and quit medicine altogether, which I'm so happy to say that I've really been able to take that painful place and turn it into a passion using the platforms that I've been fortunate enough to be given. So these are some of my colleagues. I found my people a couple of years after starting as an attending at UConn. And I joined the Academy of Breastfeeding Medicine. There are a lot of other doctors like me, apparently, who are obsessed with breastfeeding and chest feeding, human lactation. You'll notice, just as a caveat, we're trying to get away from using the terminology breastfeeding alone, just to be more inclusive of gender nonconforming and non-binary and transgender patients. So you'll hear me, I've transitioned a lot of my slides to be more inclusive of chest feeding and human lactation. Anyway, I also serve on the ACOG breastfeeding expert work group. And so these are some of my colleagues who work on creating some of that education for ACOG to disseminate nationally. So what am I talking about today? Well, by the end of this module, I'm really hoping that I can help you offer comprehensive counseling to your patients when it comes to making informed choices about how they feed their infants. It is a lot deeper than what I was trained to do in residency, which was not much, which was, are you breast or bottle feeding? End of story, great, way to go. I didn't know much, which ended up making me struggle quite a lot as a mother. Secondly, I'm hoping that I can address common concerns that you might see in the office in the postpartum period. These recommendations are really based off of the recent publication in February of this year, Breastfeeding Challenges. It's a committee opinion from ACOG that I helped to write. And I'll walk you through all of those really common things that I really do believe OBGYNs have the capacity to know and help their patients with, and it can make a huge difference knowing this and knowing how to help patients. And then lastly, I want to review safety of medications, illnesses, and exposures when your patients are lactating. A lot more people are choosing to feed with human milk, and a lot more people are being exposed for longer periods of time because they want to feed their babies for the recommended amount of time, 6 months exclusive to a year and beyond, but we'll go into that. So it's really important that as OBGYNs and obstetrical healthcare providers, we understand the position that we're in. We are in a place of privilege, really, and we can make such an impact just by a few words of what we say to our patients about how they choose to feed their infants. And again, we're uniquely positioned in that we see them so many times as they're making these decisions. Now, that being said, most people come into the office already having made up their mind. So it's really less of a struggle of how do I get my patient to want to do this? I think the message is out there. Everybody got the memo, but it's really kind of achieving that goal that we need to be better about. How do we support these patients? And also for those who are on the fence informing them in a way that they can make an empowered and informed decision about what they choose to do for their baby, which means they need to know the facts, and which means we need to know the facts. So there's some basic building blocks of successful human milk feeding, that is, people meeting their own goals for feeding with human milk, breast or chest feeding. It does require a bit of patient skill, which usually is established in the first couple weeks of learning to feed your baby from the chest or breast. The baby also has to get on board. So if you have latch issues, that could be more complicated. And then you also have to have adequate milk supply. So those are the three basics. But the fourth piece that I want to emphasize here today is that knowledgeable support is key. There are not enough lactation consultants to go around. They cannot treat medical conditions. They often have to partner with the doctor's office to be able to even prescribe for common infections and painful issues that your patients might have. And you may run into patients calling you for these types of things to help in the office, and you may not know, you may not have ever addressed these things. You may not have been trained to do that. So I'm going to try to create that knowledgeable support, at least here at GOGS. A recent study showed in 2020 that, this is all true. We all know it. The landscape analysis of breastfeeding related physician education in the United States is lacking. There still are not robust curriculums. We borrow from other specialties. The American Academy of Family Medicine has released a comprehensive educational guide for medical trainees that can be used cross specialties, but it certainly is not uniform. And as I said before, with people breast and chest feeding for longer periods of time, these lactating patients are approaching all aspects of the medical system. So it's really important that we address these limits and address these gaps in education where we can. And what this study showed also is that the gaps really are centered around three basic things. Physicians do not feel they have the knowledge base to be able to help their patients when they do run into challenges with lactation. They also feel uncomfortable with how to support because of the lack of knowledge base. And then lastly, the clinical skills. So maybe they can see that something looks very wrong when they bring the patient and do a physical exam, but then they're lacking the clinical skills of what to do next. How do you follow up? What's the best practice? And so we've really been working hard at the ACOG breastfeeding expert work group level to get this information out there to all of you. It is easy to access, acog.org/breastfeeding. You can find a lot of these modules and educational materials and resources there. But let's go through Georgia, since we are in Georgia. So Georgia, you can see here the US national average of ever breastfeeding. We are 84.1%, which keeps trickling up every year. Awesome news. If you look at what we recommend as medical providers, exclusive breastfeeding, which means no formula, no water, no supplemental foods, we're at 25%. It's a huge drop. And then if you look at Georgia, we're below the national average on all of these parameters that are being measured. And this is from cdc.gov/breastfeeding. So let's work on our knowledge base. I have some feelings, maybe guilty feelings about the way I used to counsel patients before I knew better. And, today is the best day to start doing better in our own practices. So let me teach you some pearls and hopefully you can take them with you. Let's review first the anatomy of the lactating breast. As many of you know, the breast is kind of made out of lobules, and when throughout pregnancy, these lobules develop into milk-making capacity, and it all feeds into a duct system, which comes out at the nipple. There are a lot of pieces to this, though. You can't just have milk in the breast and make it work. You really need some sort of suckling action, which can be done at the breast or chest by the infant, or through hand expression, or through pumping with an electric or manual pump. But either way, there needs to be some sort of stimulation at the breast to be able to take that food out and to get the milk ejection reflex to happen. When something stimulates a lactating breast, the hypothalamus is triggered, which then triggers the anterior and posterior pituitaries to release prolactin and oxytocin. And these two hormones are really important for both milk production and milk ejection. So what I try to explain to people is you can have plenty of production, but if you don't have that milk ejection reflex, it's very frustrating. You can get engorgement, the milk doesn't come out. Now that's really rare. Sometimes you see that after breast surgery with nerve damage, but basically that milk ejection reflex is like a hand on a full water balloon. Rapid suckling from the baby or from the pump or however it's done on the breast initiates the opening of the floodgates. And after that first couple minutes of rapid suckling, the floodgates open, hand squeezes the water balloon, tons of milk comes out at full force, sometimes very early on. And then the baby can, or the machine, whatever is taking the milk out, can kind of slow down and do slower, deeper gulps of the milk to empty the breast or chest tissue. And I say all of this just to emphasize that this whole process is about supply and demand. So if you are not removing milk regularly from the chest or breast, the body gets a signal that you don't need it. So this is why it's so crucial in the very early days that patients understand when they actually have low milk supply, and also physicians understand the definition between adequate and non-adequate milk supply and how to help patients. If the first thing you do is introduce formula, your body misses that signal that it needs to maintain a certain amount of supply, and it's a self-fulfilling prophecy. The milk supply drops. So even if the baby can't feed, even if you have technical issues with the latch or whatnot, emptying the milk regularly like the baby would be feeding is going to keep that supply and demand cycle going and keep the supply where it needs to be able to exclusively breastfeed or chest feed. Human milk feeding, as many of you probably know, is a key modifiable risk factor for many, many diseases. So in infants, we know that there's a great decrease in lots of sometimes morbid infections, H. flu, pneumonia, cholera, E. coli, rotavirus. And then, but what I think patients probably know less about is the benefits that human lactation confers to them the longer they go feeding their infants from the chest or breast. And so what we do know is that this act alone of feeding with human milk lowers patients' risks of breast, ovarian, endometrial cancer, even obesity, type 2 diabetes, hypertensive cardiovascular disease, and metabolic syndrome. Let me just explain to you the impact that this has. There are 84.1% patients in the US who initiate lactation. They want to do it, and only 25% right now are able to reach that goal. A very conservative study was done that tried to estimate what is the impact, because it has such far-reaching impacts on society, on mothers or parents, and on the infants. And so many illnesses could be prevented by just enabling patients to meet these goals. So you see where we are now. If at 6 months we had a 90% adherence rate to that exclusive human lactation recommendation, our country alone would save over 3,000 mostly infant lives a year, and $18.5 billion annually in health economic costs. Now just try to wrap your head around that. We have an intervention. We have an amazing intervention, and people are suffering, and there is a piece that many of us could help with as medical providers. And so I'm going to try to help us do our piece more effectively. So first things first, ensuring an informed decision. We really need to kind of get away from the benefits of breastfeeding way of counseling, because it minimizes the risk that's introduced by voluntary formula feeding. And so, or maybe it's not voluntary, maybe they feel it's a necessity and it may not be, but without, just knee-jerk making that decision lightly does introduce all of these health economic risks that are preventable. So we need to emphasize that as well, and not just say it's great for baby. That being said, counseling should be evidence-based and without bias of personal experience. And this goes both ways. We may have, I've heard physicians say, oh, well, my kids were fed with formula, so you'll be fine. I was fed with formula. And likewise, people who had great experiences may push breast or chest feeding on patients when they're not ready and when they don't want to do that. And so, we need to check our biases and just make sure we are presenting facts, almost like consenting for surgery. It's shared decision-making about how you feed your infant. It's a very personal decision. I went over this before. The recommended time is 6 months exclusive and 12 months with complementary foods. And then we want to make sure we support each person's informed decision about how they do choose to feed their child at the end of the day. Again, we have 9 months to take care of this counseling and to do it in a patient-centered way. So let's move on to clinical skills. Troubleshooting common lactation challenges in the postpartum period. Again, this is going to be based off that ACOG committee opinion summary that came out in February of this year. And we really tried to nail down the bare bones basics that we feel that OBGYNs could address in the postpartum period. And unfortunately, a lot of that information was lacking when we were all trainees. So trying to catch everybody up. Engorgement. Engorgement is normal. It usually is, and it's usually a good sign within those first 3 to 5 days that that full milk supply is coming in. That being said, it can be really painful, and it's not just your full milk coming in. It can include edema of the breast or chest tissue that kind of flattens out the nipple. It can make it really difficult for the babies to latch, and if you're not appropriately, taking care of that engorgement, sometimes that pain alone can, be a no-go for patients. They're like, I cannot do this. And so if you don't know how to tell them to relieve engorgement and to kind of get through those first few days of engorgement, it can be a hard stop for many patients. So it does vary in incidence and severity. And the way to treat early engorgement, normal engorgement, is to express minimally. So I think a lot of people get confused. They're like, just get it all out, put a pump on and just like fire away. But that's actually going to make your body think that you're feeding triplets. So it can make it worse. You can really ramp up. Once that milk supply is in those first few weeks, your body is just listening to all the signals and saying, oh, I need to feed a small village. So this is where oversupply becomes an issue. And oversupply is not benign either. Oversupply means you're constantly producing, you're constantly on this like hamster wheel of needing to relieve that pressure. And if you don't, you get milk stasis, and you end up getting infections, mastitis, things like that, which I'll go into. But overall, engorgement in that early postpartum period, just when the full milk comes in, can be normal. Manage it expectantly. You don't have to empty completely. I tell people, just like get the top off, like just an ounce or two, just you can hand express in the sink. You don't even have to save it, but just relieve it enough to soften that nipple areolar complex so that the baby can latch on and the baby will take care of the rest for you. This is kind of that hard first couple of days where you may feel like a bad parent because you're like, oh my God, get this kid off of me. But at least we're not like these animals that toss their babies at predators so they can escape. Those first few weeks are tough though, don't we all know? So persistent pain. This is a very common cause of early and undesired weaning, and the differential diagnosis can include a lot of different things that it could be its own lecture, diagnosing persistent pain. Could be latch, could be infections, could be tongue tie, it could be, open wounds from, the latch issues that you can have. And it really requires a focused H&P. Bring the patient in, take a look, see if you can figure out what's going on. And it's really, really important to get on top of this because patients with persistent pain are often told by peers or support groups online that it's normal, and it really is not, and it can be very depressing. Not all pain is normal. What we do say is that when those first few days, right in the middle of all the engorgement fun, that latch can be super painful, but it should get better throughout the feed. It should not be persistent pain throughout the whole feed. So if they latch on and it's like, and then it gets better, that's normal. And that can, I tell patients, it's like at the beginning of summer when you get your flip-flops on for the first time, it just really rips up between your toes and you muscle through it because you know it's worth it. You just kind of build that tissue up. It's the same with nipples. They're not used to that wet, constant friction in the first few days. So if you can muscle through that and there's no other issue going on, great, it does get better. But if it's going on for months, that ain't normal. And that is a very common reason for patients to stop altogether. And the depression comes from feeling like a total failure, feeling like you're not strong enough to muscle through pain that may actually be pathologic. So the best thing to do, bring them in, take a look, see if you can identify something, call in your lactation support to see if you can get another opinion if you're not familiar with what these things look like. Low milk supply and the use of galactagogues. This is the number one reason, low milk supply is the number one reason that patients stop and wean from breast or chest feeding before they're ready. And oftentimes, as in my case, it was perceived low milk supply because of lack of education, because you're reading all these books and thinking you're supposed to be feeding a small village with your milk supply, and you're not. It is adequate. And this is the part that we really need to be able to explain to our patients. It's a frequency thing. If your baby is eating 8 to 12 times a day, that's normal. And it is hard to not know what's coming out, especially if you're not pumping. Like, is it getting enough? If your baby's gaining weight, it's feeding frequently enough, and it's making wet and poopy diapers, and the poopy diapers are changing colors, all good signs. we can really partner with our pediatrician colleagues to be able to diagnose issues early on. So this is really why it's important for, exclusively human milk-fed babies to have close follow-up after discharge from the hospital with pediatricians to catch early feeding problems. Because again, it could be supply, it could be a maternal issue, an anatomic, or maybe the supply's not in, or or something wrong with the latch, or the baby's not suckling well. Any of these should be diagnosed early to prevent other issues. The way to fix it, I was talking about before, is frequent emptying. You need to keep that supply and demand. You have baroreceptors in the lactating breast chest tissue, and so it looks for that pressure release to refill. So you need the signal to the brain, and then you need the tissue to be emptied somewhat to be able to refill it back up. And so if your body thinks you're feeding triplets, it's going to amp up that supply. Timing is really crucial too, because it's really hard to get that back after they've introduced formula or come up with, and they've stopped signaling to the body. So this is really, we're talking first 2 to 4 weeks, trying to troubleshoot all of these things really early on. Galactagogues, Reglan, domperidone. I don't know if you've heard about it. I don't know if you've had people asking you to prescribe it. Some research has been done on this, and it is not supposed to be first line. Most people do not need galactagogues, and they're not well studied. And in fact, Reglan, I don't know if you know this, taken routinely can really exacerbate psychological, like depression, anxiety. I know lots of people who became quite depressed and suicidal by trying to self-medicate, doctors self-medicate with Reglan to increase their supply, when actually all they needed to do was increase frequency, or maybe their supply was fine. So please, please, please do not knee-jerk give Reglan. Domperidone's not even legal in this country, but I know people who order it from Canada and get it shipped down just to increase milk supply. There are all the milk teas and everything. It's a supply and demand thing. And if you stop watching the clock and stop being so rigid about it and just feed the baby, be an open buffet. I could do a whole talk on this, but the take-home point is we do not recommend galactagogues as first-line therapy, and you really should be seeing a lactation expert by that point before you prescribe that. Mastitis, very sad situation. As I said before, definitely oversupply is an issue. If you're so full you can't even empty everything, there is milk stasis in those ducts. A blocked duct turns into mastitis, diagnosed, as many of you know, with extremely high fevers and a wedge-shaped red spot on a unilateral breast or chest. Can also be associated with nipple injury, latch difficulties. Again, anything that's going to keep the milk from coming out regularly, backs up the system, can get infected. Early recognition is key. Without fevers, if it's just kind of the wedge-shaped redness in a blocked duct, ibuprofen, massage, frequent emptying on that side to kind of get ahead of the infection. But if now they got fevers, obviously we want to prescribe antibiotics early on before they become abscesses, or drop the milk supply completely. We do expect a slight drop in milk supply just naturally from this process, but it does come back. But just being sick, your body's not functioning as well. You definitely want to encourage feeding during this, again, because the stasis is going to make it worse. So frequent removal as you're treating with antibiotics and anti-inflammatories, all very safe. Preterm and early term infants. Oh, they are. They act their age and they're just kind of tired. They need a little anti-murdery juicy juice to get going. And so we definitely see more issues with late preterm and early term infants. And sometimes they're big enough where you would think that they'd be just fine, but they're not. They are less alert, less stamina, they're tired, they can't quite get, the neurodevelopment's not quite there. And so swallowing, sucking, it's really hard. So a lot of these parents need to express to get the milk supply up and to feed in alternate manners until the baby matures enough to be able to do that. The other complicating factor is the parent side. So these parents tend to have more medical conditions that can delay lactogenesis or the development of that mature milk. So, 3 to 5 days, your mature milk should be coming in, but diabetes, obesity, hypothyroidism, all of these medical conditions that we see in Georgia all the time are risk factors for delayed lactogenesis. And then early term and late preterm infants can often be multiples, which also adds another layer of complications. So it's hard to make the milk and make it adequately. And then you have a baby you're trying to feed who can't quite get the act together either because they're just a little young. So you really want to get ahead of this, call in your lactation support teams, encourage hand expression. That's a huge helper. One of the trends now, I'll say, in the breastfeeding medicine world is doing kind of keeping the pipes open by constant, or regular frequent hand expression. So you don't have to empty completely, but if they're just sitting there, and it's in between feeds, sometimes just kind of squeezing a little colostrum out early on, it signals the brain. Anything you do is going to signal the brain, and the brain's like, oh, I got triplets here, so you don't have to collect the milk if you don't want to. You can just, and it's easier than like setting up a whole pump and cleaning all the parts, like just hand express a little bit from each side into a washcloth just to signal your body. And that usually ramps up the supply really well too in these difficult situations. Palpable breast mass. So pregnancy-associated breast cancer accounts for 3% of all breast cancer diagnoses, and is really confusing and very sad. And the rate is increasing because more women are giving birth later in their reproductive years. It carries a worse prognosis when diagnosed postpartum, and so obviously prompt evaluation is so important. If a patient comes to you with a breast mass, don't brush that off. If it looks like a blocked duct, and you can confidently say it's a blocked duct, and great. But if there's any concern at all, breast ultrasound is first line, especially when that tissue is very different during the lactation period. If something looks suspicious on breast ultrasound, then you would move on to diagnostic mammogram. But our lives are short. These are new moms. We need to do our best and not minimize if somebody has a concerning mass. Make sure that we bring them in quickly. There's no fever, sign of infection. Definitely get some imaging to make sure nothing else is going on so we don't miss these things. Okay, so on to contraindications. There's a review on this, medications, other exposures. So not recommended. Notice there are only like 5 things on here. There are so few actual contraindications. So this data is from the cdc.gov/breastfeeding. And I kind of put it in a nice little slide. So when you cannot give any human milk, these are the conditions. Galactosemia, baby cannot digest it. Very, very rare, but obviously that's a no-go. It would kill the baby. HIV, I have another slide on this. In our country, the recommendation is a hard no, but that is our country. I'll go into that on the next slide. T-cell lymphotrophic virus type 1 or 2, PCP and cocaine use, and Ebola virus. Okay, so these are the hard no's. As far as HIV goes, this is really interesting because we do see some patients coming from other countries where breast or chest feeding is recommended with undetectable viral load, well-controlled HIV. And it's come to our attention that patients come and, fly on an airplane, come here, and all of a sudden the rules are different and they're told they can absolutely not, they will harm their babies, even with an undetectable viral load. Now, many of you may remember not so long ago, HIV was a very scary thing that, was not the chronic disease that it is now. But many, many patients live with HIV without any viral load. And there's a lot of research being done right now to validate the hypothesis that undetectable means, untransferable to babies too. So what we do know is that the CDC recommendations for absolute hard no on the breast or chest feeding with a patient with HIV was actually based off of one case report in like 1985. They saw that it was transmitted and they said, we just can't allow this. And that has not been updated. Although, as you can see here, in 2019, the Journal of International AIDS Society is pushing back on that. It doesn't make sense. And we may see this very soon, that these recommendations change, because when you weigh out the risk benefit, some patients may actually be okay with the less than 1% risk of transmission of HIV to their infants through human milk versus other risks that we're introducing by feeding with formula. So the way we approach it at Grady is, we educate the patient. It's an informed decision. They do run up against a lot of barriers, especially with our pediatrician colleagues. But they're lactational surrogates. They can, heat treat the milk. There are other things that they can do. They can breast or chest feed on their medications if they would like to. And ultimately, it is up to the patient's choice, but we need to make sure they're aware of all the risks on both sides. Pump and dump. Also a knee-jerk reaction for lots of people. Go tell everybody to pump and dump. If you don't know, there's no reason for that. Look it up. There are a lot of resources, but these are the real reasons to pump and dump. So something is wrong with milk. Okay, you don't want to lose the signaling to the parent. So you pump so that your body's still getting all the messaging to keep the supply up, but you dump the milk because whatever illness or exposure is actually there on the skin or on the milk. So can be transferred through the milk. So these are usually temporary interruptions. So if you were to say, just stop breastfeeding when you are taking certain medications, then they lose that supply and demand and the milk supply drops, and then you're introducing formula. So for patients who really want to maintain this relationship with their infants, these are the conditions. Brucellosis, certain medications, as I said, and these can all be looked up. There are plenty of resources for that. Some imaging studies, radiographic studies that kind of stay in the milk. And those are your radiology colleagues usually know which ones are contraindicated for a short period of time. And then active HSV of the breast right where they're feeding can also infect the baby, right? And then express or pump and feed. Okay, this is when there's something on the body that, it's like the exposure to the parent is the issue, but not the milk. It doesn't transfer into the milk. So untreated active TB, those patients can be hospitalized and treated and pump the milk, and the milk is fine. So the milk can be given to the baby, so they still get the supply and demand when separated from the infant. Also active varicella, same kind of thing. Transfer of drugs and therapeutics into human milk. So as I said before, one of our major concerns in the medical community across the board is the misinformation that's coming from the medical community. Many healthcare providers have been known to inappropriately advise patients to discontinue or avoid medications. And the thing I always hear is, well, you never know. And so just to be safe. But like I said before, there are very few contraindications. And just if you think of the power differential that we are in as physicians talking to patients, all it takes is one misinformed physician to say the wrong thing to scare the patient out of doing what they've been working so hard to do. And hopefully you understand now how much work goes into feeding with human milk. So here are some resources that I like to go to. And so, look it up. I think a lot of EMRs have resources built in that are very helpful as well. Things to consider before starting a medication on a lactating patient. Really, this is also a step back and kind of a change of mindset for us healthcare providers. We are so used to just prescribing and giving, but we need to consider that, there's more to this picture when it's a lactating patient. How old is the infant? What is the breastfeeding, chest feeding relationship of the parent and infant? How much exposure would the infant actually be getting? If it's a 9-month-old baby that's only feeding at night, maybe it's a minimal exposure and they can give medication in the morning, the half-life's gone by the end of the day, but it's a complicated thing. So obviously you could just pick a safe medication if the patient really needs it, boom, you're done. If it's something with a little risk, rather than just being like, absolutely not, you have to stop breastfeeding because you have to take that, just take a step back. Consider all the pieces of the puzzle. How many of those feeds are actually going to be affected by whatever the drug is? And let the patient join in the decision-making. They need to know the risks of not taking the medication and the risks of taking it and exposing the baby. And so get the facts and help your patients make that type of decision. And then wait. If it can wait, you wait. Breastfeeding and chest feeding human lactation is hard, and it is really important to a lot of people. So we don't want to minimize that need for these patients as well. Look at the health effects of being successful at it, and weigh that against the need for this medication right now today. Just an update on the MEC guidelines. These were updated a few years ago, and one of the notable changes is really inclusive of people who choose to feed with human milk. They've changed this less than 1 month postpartum to a 3 for anything with estrogen in it. And this is mostly because it's to account for basically the desire to establish milk. There have been very conflicting studies about the effect of contraceptive on milk supply. But that being said, if the patient within a month postpartum is not going to be having intercourse and they don't need it desperately and they're trying to establish milk supply, they need to know that any medication can, in fact, have the side effect of decreasing milk supply. And so, even if it's rare, they should know that before they make the decision to start a contraceptive medication. And if it's safe to wait until 1 month postpartum, which is when the milk is better and more adequately created, the supply is created, then, that should be an option for patients as well. Drugs of abuse, cannabis and THC, insufficient data, but the message that we're giving from the public health arena is that it is discouraged, just like many other things that we don't have enough data on. Methadone, Suboxone is good if it's given in a controlled fashion. Obviously, off the street, no good. But if you're treating a patient with either of these medications, this can actually help decrease neonatal abstinence syndrome. And so we do encourage that use, and we do encourage human milk feeding for those babies to help wean them off of these things that they were exposed to during pregnancy. Codeine and tramadol, lots of black box warnings on these. We just don't know which babies are going to be ultra rapid converters of these meds, and that can cause respiratory depression and death early on. So that is contraindicated. Another word on marijuana, there is exactly one study that was done in 2018 and, randomized controlled trial to really try to evaluate how much marijuana is transferred into human milk. And so obviously not many moms volunteered for this opportunity, but they were able to get inhaled THC, give it to these specific moms, and measure how much came out in the milk. And what they found was only 2.5% of the dose that the mom took came into the human milk. Again, we do not recommend this during pregnancy or during lactation. That being said, the amount that actually makes it to the baby is quite minimal and might not be that significant, right? And the reason that as it's coming into the baby is so minimal is that it always comes in as an edible THC to the baby. It goes through a first pass effect. So if you think about edible marijuana, you take higher doses because you lose some of that first pass effect. But even if the mom is using inhaled marijuana, to the baby, it's coming in as an edible, right? 2.5% of whatever she's taking is coming out and then going through first pass effect on the baby. And so the amount that actually affects the baby is quite low, but we cannot comment on safety profiles at this point. Other exposures, nicotine, obviously smoke exposure increases risk of SIDS. Try to encourage other therapies. Alcohol, common misconception, it is not contraindicated. What the official recommendation is to wait 90 to 120 minutes after ingesting one drink. And moderate intake is not harmful. Again, very minimal amount that actually ends up going into the milk. The serum blood alcohol level equals the milk level. So this is not the proof of the drink. It is the digested amount that's in the blood that actually is in the milk. So if you think about it, if the patient is feeling buzzed, then there's a higher serum level, and then that is what the baby's taking into. So be safe when you can. Try to spread it out and not feed when you're feeling a buzz, but you do not have to pump and dump that milk. If you go on a bender one night, pump before, and then wait till it gets out of you don't feel buzzed, and then you can express the milk after and it goes away. Caffeine, we need that for survival. Up to 300 milligrams is safe. And then some vaccines are actually contraindicated, smallpox and yellow fever, not COVID though. Diagnostic imaging, we talked about before. Hopefully most everybody knows that ultrasound is definitely safe. MRI, even with contrast, definitely safe. X-ray, safe. CAT scans, even with contrast, safe. So don't let any, physicians in the ER tell you that, or tell your patient that they can't have these imaging studies when they're lactating. I feel like people have caught up to this information. It's really your nuclear medicine that's going to be the issue, because the radiation comes off the patient after they've been exposed to this. So again, this is a pump and dump. Pump to keep the supply up, dump the milk because it's exposed to these chemicals. All right. So in summary, we can actually help impact our entire society, the health of infants and parents across the globe by just supporting and giving better information about human lactation. Misinformation can be detrimental. Like I said, it only takes one wrong thing from somebody in power for a patient to doubt what they're doing and change everything, introduce formula the first time, and kind of sabotage all those benefits that they may have been trying to achieve in that lactation relationship with their infant. There are very, very few contraindications. Please, please, please look it up. Please look it up. Just look it up before you tell a patient that they need to pump and dump, because many times that's not true. And then let me go on to, so this is my email information. This is my now 6-year-old. I forgot to print all his baby photos, so they end up in all my PowerPoints. You can find me on Twitter at wholehearteddoc, or you can email me with any questions. And with that, I'm going to stop sharing, and I'd be happy to take any questions you might have. Thank you so much for coming. Really appreciate it.